Welcome to the Rural American Surgeon. I'm your host, Dr. Randy Lehman, a general surgeon from Indiana. This show is tailored around the nuts and bolts of rural general surgery practice. You will find topics such as practical surgical tips, rural lifestyle, finance, training, practice models, and more. We have a segment called Classic Rural Surgery Stories, where you'll get a feel for how practice in the country differs from the city. If rural surgery is your passion, this show is for you. So, now that the ChloraPrep has dried, let's make our incision. Welcome back, listener, to another episode of the Rural American Surgeon podcast. I have a special guest today, Konstantin Grigoryan. He is a dermatology surgeon practicing in California who went to medical school with me, was a valedictorian of my graduating class, and did his internship and then followed me up to Mayo Clinic, did derm residency up there. And now he's going to tell us all about what he's doing. And because skin cancer is one of the most common things that we see in rural America, and a lot of us are taking care of it, we're going to talk about a lot of aspects of skin cancer. So, Dr. Grigoryan, thank you for joining me today.
My pleasure. I'm happy to be able to be part of this.
Yeah, it's awesome. So you have a little bit of a non-traditional and interesting background, and I just want to start with an introduction of you. So tell us your background and how you got to where you are and what you're doing now.
Yes. So a little bit about myself. I grew up kind of originally from the former Soviet Union. We were refugees, ended up in a small town in Kentucky called Bowling Green. I don't know if you guys are familiar with that, but that's where Corvettes are made. And grew up there. Then when I was in high school, we moved to Cincinnati. And since then, I kind of decided to join. My parents were both engineers back in the Soviet Union. That's kind of what I knew. Kind of always growing up, I liked taking things apart, fixing things. So I pursued engineering. I studied electrical and computer engineering. I did that for 6 years, but it kind of wasn't what I thought it was going to be. It was a lot more project management, kind of working for a large corporation. I felt like I wasn't having an impact on people. And I decided to go back to med school kind of 6 years after working. Took a couple of classes to meet the pre-med requirements, applied, and luckily I was able to get in. Ended up studying with Dr. Lehman and chose dermatology for my field. I went to Mayo Clinic in Minnesota, spent 3 years there. Prior to that, I went to Boston for my intern year when I met my wife. She kind of followed me to Mayo Clinic. And after that, I did a 1 year fellowship in Mohs micrographic surgery at the University of Washington in Seattle. And after that, after the fellowship training, I moved to Sacramento, California, where I've been working at the VA here in town, and it's affiliated with UC Davis, so I get to train residents, which is quite fun, part of the dermatology training. And we work closely with other specialties as well, especially with the Mohs micrographic surgery, Mohs Surgery, where we share a lot of skin cancers with head and neck surgeons or general surgeons, etc.
Yeah. So thank you. And is that like 80% of what you do? Is it Mohs? I mean, what's the breakdown of your practice?
So mostly Mohs, but we also do just surgical excisions. Everything we do is an outpatient basis, local anesthesia. The majority, I would say, about 60 to 80% Mohs and then 20% excisions. And I just want to mention that, I'm based out of Sacramento, but the VA here covers kind of all of Northern California outside of San Francisco. When people think California, they think of like the big cities, but gets rural pretty quickly outside the big cities. And we cover, all the Sierras up to the Oregon border. So we have a lot of kind of lack of access to care, especially with the veterans. And we see a lot of neglected tumors or patients that have frankly been mismanaged, unfortunately.
Yeah. So this next episode, we normally ask people, why is rural surgery special to you? But in your case, you specifically chose Mohs as the thing. So why Mohs? Why is that special to you? Why do you think it's important?
One thing I love about Mohs is kind of a couple things. One is I like talking to the patients, when I'm operating on them. They're awake. So I'm kind of having a conversation, getting to learn about them. The other thing that I love about it is I'm able to do my surgery. Then I look at the pathology myself, and I know the skin cancer is gone, and I can tell the patient, hey, your skin cancer is gone. It's pretty gratifying. I love that about kind of this field. A lot of times, as you guys know, you do your surgery, you have to wait for pathology to come back, and that can take a while, and you don't always get it. And I like that instant gratification of it, kind of, as opposed to having like a chronic thing that kind of keeps going and going.
Yeah, that makes sense. So let's move to how I do it, which obviously we're going to talk about Mohs. So I want to talk about management of skin cancer for the rural surgeon that doesn't have Mohs, but also, let's start by just diving in deep to what can a patient expect, say they were referred for Mohs. So just explain the procedure, and then I've got tons of questions.
So I'll kind of start with the history. So Mohs, M-O-H-S, it's actually named after the guy that came up with it, Fred Mohs. He was from Wisconsin. He was actually a general surgeon. The way that it differs from just a standard excision is you take your tissue, and then instead of kind of bread loafing it, the way it's processed in the lab, that 3D tissue is kind of flattened out and it's cut across. So you're able to check 360 degrees around it and all the way underneath. So you can see the full margin. The benefit of that being you can take tighter margins and evaluate it all, as opposed to when you're bread loafing it, you're only evaluating, I think, like 4 to 6% of the margin. You can imagine maybe tumor that's not in the section that was cut, and you might miss a positive margin there. So that's how it kind of differs from regular excisions. And of course, the other part being you are the pathologist yourself, so you know exactly how what you're seeing underneath the microscope correlates in situ on the patient. So when patients come in to see me, usually Mohs is done for most common things: basal cell carcinomas, squamous cell carcinomas. More and more people are doing Mohs for melanoma as well, and kind of rarer stuff like DFSPs or sebaceous carcinomas, things like that, egg nest cell tumors. When you refer a patient for Mohs, they come in, they have to know that they're going to be there a good part of the day. It takes a long time, usually about an hour, sometimes less, 45 minutes, to kind of process that tissue in the lab. We do frozen sections on it. Like I mentioned, it's sectioned to where you're able to see the complete margin. Usually start, they come in, I explain the procedure, numb them up, take a tight margin around the tumor, and I check it. And if it's positive, I have a map, I draw it out, I mark it on my map, kind of go back and repeat the process and keep going and going sometimes until you get it all out. Usually most people are probably anywhere between 1 and 2, what we call stages. I've had kind of some outliers where it's like 8 or 9 stages, and you're there all day into the evening, and some patients can't tolerate it. They bring them back the next day or later in the week. And after skin cancer is gone, figure out the best way to get things to heal up. Sometimes we can let things heal by second intention. Of course, primary linear closures, and things can get more complicated with different types of flaps, advancement flaps, rotation flaps, transposition flaps, and then kind of the more complicated stuff, you have interpolation flaps. Kind of the one that's the most utilized, or one of the most utilized, is a medial-labial transposition flap or a forehead flap from the forehead. In my practice, I find the patients don't really love the forehead flap, so I try to avoid it if I can. Mm-hmm.
So yeah, and it's kind of what the patient can expect. So you're saying that first off, you're taking the specimen out, and then multiple times you're doing essentially your own frozen section, but the difference is it's rather than being slices, it's being the whole margin that's being checked, and then you can map it out, re-resect. My question of how many typical cuts you already answered, that you're saying 2 to maybe like 2 is an average, or 3?
My average is like 1.8, around 1.8.
But sometimes it can take much more. So who's the best patient? Not everybody. It's not conceivable that right now every single skin cancer could be excised by Mohs. So I'm thinking, if you got a nodular basal cell on the shoulder, that's probably not the right person. Who benefits the most?
Yes. So there's actually a kind of calculator that was put out. They divided the body into different parts, and the part that kind of most beneficial are the head and neck, kind of the face, where you can't take a bigger margin, and kind of more aggressive pathologies or patients that are transplant patients or immunosuppressed, where tumors can be quite more aggressive in them.
Okay. How about age of a patient?
Age, of course, I would say younger, the better. Skin cancer, my average patient population is probably around 75. But, a younger patient, I would want to do Mohs on, because the cure rate is 99% as opposed to kind of 96% with excision, or like electrodesiccation and curettage, which have like 85% cure rates. So the younger they are, I would push for Mohs.
Speaking of younger, we got a little distractor here. Yeah. Hi, Jack.
I have a couple of my own, but they're not in the house currently.
It's kind of hypocritical for me to ask my guests to, make sure we're keeping it focused on the podcast, but then at the same time, my kid's over here playing Legos and poking his head over the shoulder. So thanks for joining us, Jack. All right. So we talked about basically an aggressive. I want to talk about basal cell. So nodular basal versus infiltrative basal. Do you think infiltrative is better used for Mohs than nodular?
I would say so. Nodular basals are usually, in my experience, not, there are always exceptions, but in general, not as deep, or not as, there's not as much of a subclinical spread. You can kind of see where the margin is clinically by looking at it. Whereas infiltrative basal cells, you can't always do that.
Yeah, I mean, for me, it's just so frustrating to get a positive margin back on an infiltrative basal, but I don't think I've ever got a positive margin back on a nodular. And so that makes a big role in my decision making, as well as, like you said, location. So like nose, any sensitive area. So defect closure. So how big of a closure will you do yourself? I mean, it sounds like, are you doing those transposition flaps yourself?
Mm-hmm.
Yeah. Okay.
Yes. Actually, Mohs surgeons kind of do the most facial reconstruction of the country, kind of based on the numbers, based on the billing. Usually can handle almost everything myself. Occasionally I will get a patient that will just not tolerate a big repair. Like I had a patient that had a big nasal defect. I recommended a forehead flap, but he just jumped off the table every time I poked him with the needle. It ended up being a big tumor. I find that kind of throughout the day, if it's a long day, patients will get a little bit more sensitive or less sensitive to the anesthesia. But we can handle pretty big defects under local. A lot of times, several centimeters across. A lot of times things can granulate as well, especially on the scalp, can have huge defects that will granulate.
Yeah. So I don't feel like for my practice, I do a ton of all types of skin lesions, benign lesions, as well as squame, basal, and melanoma. On the face, non-melanoma things that I have been doing, like squames and basals, I would say an inverted A to T is a really useful forehead flap that I use a lot. I've done some nasolabial flaps. I've done some anti-abduct helical rim advancement flaps for the ear. They're actually super robust and easy to do. Also on the neck, do some rotational flaps, like just a rhomboid flap or advancement flaps. On the scalp, you can get away with nice rotational flaps and those closures. Outside of what I just mentioned, are there any flap techniques or closure techniques that you would say maybe a general surgeon who's doing some of those, like I said, those simple squames, nodular basals, and things that are on the head and neck that they should really look up and consider using?
You kind of mentioned most of them. You have O to T, you can have O to L, which is just kind of one-sided one. Smaller defects can be closed with an O to L. The transposition flaps of different sorts, kind of the rhombic is kind of the standard one. A lot of defects can be closed, on the temple, sometimes around the nose too. Other things, you can use rotation flaps on the nose sometimes, like a dorsal nasal rotation flap, or a bilobe flap can be useful for nasal defects as well. Or not only nasal defects, but other big defects, because you're kind of transposing quite a bit of tissue by 90 degrees.
A mucoid cyst of the finger. I love that little bilobe flap. Boom. Closed, walk away, no defect in your nail long term. It's kind of nice. I had a patient with a very large squame of the lower lip. I did, I did some reading. I like to put myself in the situation. What if I was the last person to deal with this and then not actually do it and send them somewhere else? But there's a mental exercise that goes through, first off, having a boundary, but thinking if you were outside of the boundary. So, talking about trying to close with some sort of triangular or W-shaped flap. Do you do anything like that? Full thickness lip stuff?
Mm-hmm. Yeah. You can do a full thickness wedge excision on the lip. Up to around a third of the defect or a third of the width of the lip, you can get away with that. And just full thickness repair, you have to repair the mucosa, submucosa, muscle, and then the skin. And then you can also do interpolation flaps, which I haven't really done for lip defects as well, where you borrow kind of, let's say if it's a lower lip defect, you'll transpose based on the superior labial artery, the top lip onto the defect, kind of let it attach itself for 3 weeks, and then come in, sever the pedicle, do the flap inset.
Yeah, and that's how you do your nasolabials, right? You sever it.
Yes. Mm-hmm.
How long until you divide the nasolabial flap?
3 weeks, about 3 weeks.
Mm-hmm. Okay. How about skin grafts? Full thickness skin graft? You do many of those?
Mm-hmm. Yeah, a lot of full
What's your
thickness.
technique for that?
I've kind of been evolving in what I do for those. I usually, for smaller defects, I'll do a preauricular donor site, and I'm talking about nasal defects usually. Mm-hmm. I've been doing, my training, we would kind of glue on a bolster with steri strips, leave that in for 5 days, 5 to 7 days. They would come in, they remove that. But lately I've been having success with putting in my graft and using Dermabond and just leaving that on. And I would instruct the patient, don't peel it off. Eventually it'll fall off. And once it falls off, start putting Vaseline, petrolatum on it until, you see me in follow up in 1 to 2 weeks, and we kind of can see how it's going. So I usually, harvest my full thickness skin graft. I try to get my depth as I'm removing it, because I think it's easier to kind of get the depth in situ as opposed to trying to hold the tissue in your hand and try to defat it, get it to the depth you want. Then I suture it in with 5-0 fast gut sutures, and then I do the Dermabond on top.
Now, the Dermabond, is it just around the outside?
I just Dermabond the whole thing, just over top and outside. Kind of keeps it in place.
No pie crust incision in the center?
No, I don't do that. I find they haven't really bled that much after the fact.
Okay. Is that, theoretically make a little fluid pocket behind there and elevates your graft, and then you lose the graft. I've heard that. So you're going all the way. Are you interrupting your 5-0? Just very fine detail, but.
I do simple interrupted sutures, but I know some people will do running continuous sutures.
Yeah. So if, say, you got a neck skin cancer and you're going to get a primary closure on it, do you do 3-to-1 ellipse or?
Yeah, 3-to-1 ellipse. I usually do have some really big defects on the neck. The older patients have a lot more skin laxity.
Right. So then how do you close it? What do you use for your, do you use 2-layer closure on that usually? Mm-hmm.
2-layer closure. My training, we use kind of Vicryl or the Vicryl equivalent, but I find I've been using a lot more monocryl, and violet monocryl I prefer. I feel like it's a little easier to handle and I can actually see it better, and it's less reactive than Vicryl in my opinion.
What sizes do you use for your sub-Q and your skin?
I usually do 4-0 for kind of the not a lot of tension, in the face. And then around the eyes, I'll do 5-0 kind of for the thinner skin. Sometimes on the really thin necks, I'll do 5-0 as well.
So would you do like a 2-layer closure, both layers with the 4-0 violet monitor?
So that's the subcutaneous layer. I use that. And for the top layer, I've been using a lot of fast gut sutures, either 5-0 or 6-0.
And that's so are you doing that like a baseball stitch, or are you doing that subcuticular?
I do it like a baseball stitch, just like a simple running.
And then they just put some Bassi over it and it falls out?
Just petrolatum. Yeah. Mm-hmm. And it'll fall out after about a week.
On its own. Okay.
Mm-hmm. I find that it does pretty good. My patient, older patients don't really want to come back for a suture removal because a lot of people will use either nylon or Prolene sutures for the top stitches as well.
Yeah, being a general surgeon, I do a lot of like 3-0 vicryl deep stitches, 4-0 monocryl running subcuticular. Every once in a while, though, you have some knots that are trying to spit out, because that's still a pretty good size suture right underneath the skin for your subcuticular. Obviously, I start it with a buried, and then I end it with a buried, tuck the tail down out the end. So, it does all right. But yeah, that 5-0 fast gut is a great technique, and those stitch marks you never see. But I mean, when that stitch just falls out, pretty fast too, to run that. Okay. So thank you for diving in deep into that. Now, my audience is essentially myself. So it's a young practicing rural general surgeon who just needs that surgeon's lounge to talk about these type of practical things. And I'm wondering, which patients should I, if the patient, a lot of these patients are too poor to leave town, and they're too or they're too old. Maybe they're living in the nursing home that's connected to the hospital, right? I mean, these are the reasons why general surgeons shouldn't be scared of skin cancer, obviously. And there's a lot of patients that we just, if it's a good sized face on a 55-year-old with no resource limitations, like they need to go to the city and do the Mohs, and then you got these other ones on the other extremes of the spectrum. For whatever reason, it's too much burden and you can't get them to do it. Or a lot of people should be just given the option, for convenience sake, to stay home and discuss it. And that's kind of how I've gotten to. I say basically I look at NCCN guidelines on these margins, and ways for excision, in a high risk area, 6 millimeter margins, which would be like forehead, ears. Those end up being high risk areas, and so according to their guidelines, you end up taking a pretty good sized hole, or non high risk, maybe more of a 4 millimeter margin. And I talk to patients frankly about it, and I'm like, you can get a smaller defect, smaller scar with Mohs, and a lot of patients still decide to stay. I would say my margin positivity rate, I don't know what it is, but I'm sure it's low single digits, but not zero. And my two questions that I have about that are, which patients should I have path in-house for frozen section for skin cancer? That's first question. Second question is there such a thing as like a good positive margin rate?
Path in-house. So you're talking about like bread loafing it, or
yes.
Like doing... I think if you're bread loafing it, then sometimes, if you're unsure about the clinical margins, a lot of times, I'm sure, you see these patients, but like, you don't know where the skin cancer starts and ends. Their skin is so bad. I think that might be beneficial. But then again, you're bread loafing it. You're not evaluating the full margin. Kind of hard to say. Whereas in terms of the positivity rate, I always say excision has about 96% cure rate. So 4% of the time, maybe there's a small risk that it doesn't get it all. Whereas Mohs is 99%. And of course it changes for recurrent tumors or kind of the really high risk stuff, whereas excision will be only 70% cure rate, and most can still have 90% plus cure rate on the recurrent stuff, like previously radiated skin, things like that.
How many of these questions have right or wrong answers?
I mean, I don't think I think there's no such thing as right or wrong in a lot of this. I mean, there are definitely clear cut cases that should go one way or another, but then there's gray area as well.
Let me give you one example of another gray area that I had like in the last 2 weeks. 92-year-old patient, pretty good size, SCC on the back. I just took it out with something like a 0.5 centimeter of margin and closed it up, intermediate closure. In one of the tips of my intermediate closure, there was an incidentally discovered SCC that was smaller that extended to the edge of the margin, edge of the inked margin. All right. So I'll tell you what I did. And, I said, come back in 3 months and let's look at your scar, because what are we really doing here? And very well may not have any regrowth at the scar, very well may be dead in 3 months. So to keep going back, like I could, I mean, that would be very clinically justified, I think, to do that as well. But, you're having a discussion, the patient is reliable, the family's reliable, and it's possible that nothing regrows there. He's got lots of other lesions all over his body. And really, you're just watching the big, nasty ones that get out of control, that are like bleeding and causing issues, and not necessarily trying to give him perfect skin. What do you think about that? What other ideas do you have?
I think that's reasonable, kind of close follow-up with if you find that the patients are reliable. In my practice, they're not always reliable and they get lost to follow-up. And then I see them, several years later with these huge tumors that have been growing. I think there are different ways to approach that. Kind of some people would go back and re-excise that. Some people might send them for Mohs with a positive margin. But if it's an incidental thing, I think, and it's a low risk tumor, within squamous cell, you can have well differentiated squamous cells, and kind of poorly differentiated squamous cells are kind of opposite ends of the margin or of the spectrum. And of course, their behavior is quite different. It's not like one squamous cell will behave. Not all squamous cells behave the same.
Yeah. So in that, I just kind of remember there's this other little, essentially skin lesion that's there. So I just happened to include it in the tail, and so that's a great thought.
That's in my practice, like you mentioned, I will a lot of times find incidental things. Being a dermatologist, I can kind of clinically tell what most things are, and I will try to include the whole thing in my tips. Or try to completely avoid it if I can. So try to avoid it off the bat, because that does happen.
Mm-hmm. So, how are you biopsying these lesions in the first place? How should I choose, I guess, if I have a lesion? When do I do a shave? When do I do a punch?
So good question. I think shave biopsies, most people probably do shave biopsies for a lot of things. That will give you a diagnosis. Kind of distinction between shave and punch. If you're worried about the depth of something, do a punch biopsy. I've had some weird nodules where they were pretty deep, and the shave wouldn't get it. You kind of have to punch it, or even do a double punch to go even deeper. That's the difference. And of course, you have the question of like pigmented versus non-pigmented lesions. I think non-pigmented lesions can mostly be shaved, whereas pigmented, you can do a scoop shave. As the cutoff between should we do a sentinel lymph node biopsy or not, staging of melanoma, if it's greater than kind of 0.8 millimeters, then it stages that the T stage is higher, and you can consider or do a sentinel lymph node biopsy. So if you're doing a scoop shave of the lesion or punch the whole lesion out if you can, sometimes you can't do that. Or even I find that melanomas, if they're large clinically, I try to get the whole thing out with a tight margin to give me the full picture, because you don't know what you're biopsying. You could biopsy a sample that's not representative. I will get these all the time. It's like, oh, I have a 3 centimeter tumor, 4 centimeter tumor. Biopsy shows melanoma in situ. They come in, I'm like, I don't like that. What margin am I going to use? I'll go ahead and just do a tight, 1 millimeter margin, cut it out with a scalpel, and just either let it granulate or purse string it and get the full pathologic staging. And I've had cases that have been, set MIS on biopsies, and I did that, and they came back as like 1.5 millimeters in depth or whatnot, and we sent them for sentinel lymph node biopsy.
So you don't do sentinel lymph node biopsy in the clinic setting, obviously. Okay. And so you're doing sentinel lymph node biopsy after excision of the lesion then?
So I just call it like an excisional biopsy with like just 1 or 2 millimeter margins. Mm-hmm. And if it needs it, then we send them to general surgery. They'll do the wide local excision with the appropriate margin and the not sentinel lymph node biopsy.
Mm-hmm. Okay. So
I try to get the whole lesion out, for staging purposes.
So you're just excising the scar. The general surgeon is just excising the scar then, basically.
Mm-hmm. Yeah.
Right. Okay. That was one other question was, do you do dermatoscopy at all?
Dermoscopy?
Dermoscopy, sorry.
Mm-hmm. I use it. I find that it can be helpful sometimes to distinguish between kind of something appears benign or does it look like a basal cell versus like pigmented stuff. Is this just a lentigo, or it can help? Does it have features of melanoma?
So I think it was in the 1980s, the current procedural terminology was released. Now we live and die by these 5-digit CPT codes. It's been around ever since we've been practicing medicine. I have a couple questions about that, and maybe no or don't. But there's a set of codes called shave excision, and I use those codes when I'm shaving something with the intent of completely removing it. And is that correct?
I think it's correct. I'm not the best person probably to ask the billing questions because I work at the VA. It's not that important for us.
Yeah, sure.
But if your intent is removal and you kind of know what it is, then I think shave excision would be okay. I bill everything as shave biopsy because I don't know for certainty what the lesions are. I'm trying to get a diagnosis.
Like for example, you get this, maybe it's an irritated SK or it's an actinic keratosis or something like that ends up not being a full skin cancer thing, but a lot of times they're symptomatic. And so and they're in a place where, you talk to them about, you could excise it with margins or whatever, but you could just do a shave and let it heal by secondary intent. And that's probably going to be a really acceptable scar. And depending on, like I said, on size and location on the body. And so that's when I use it. They're like 113 and then whatever the code is rather than shave biopsy. So anyway, question that I think the coders have been agreeing with me on it. So that's kind of how I've been choosing to do it, but okay. Well, let's move on maybe to the next section of the show that's called the financial corner. So do you have a money tip for our listener?
Money tip, I guess, slow and steady, wins the race. I'm kind of a low risk person, I would say. I don't know. I'm in the, I would say, boglehead. I don't know if you heard that term before. Sure. Just kind of total stock market investments, S&P fund, or the full stock market, and kind of see where that goes. Historically, it always goes up with like 7 to 8% annual returns.
Yeah, it's a question. Do you believe in the future of America, which
or the world?
I do more than anything else.
Yeah. I think that's what it boils down to. Do you think capitalism will continue working as it has been for the last 100 plus years?
Right, at least in the short term. And when I say short term, it's your long term, but it's the short term of the overall world. So
yeah.
Okay, wonderful. I've got a story. So for classic rural surgery, a lot of times there are these things that, you just see, and it's the 1 in 100,000 like diagnoses that I still run into in a town of 1,200 people or whatever. So I had this one guy that came in, and it was SCC on the scalp, and he actually had it excised, and there was a positive margin, and that was done by the primary care, 5 years before or whatever. And it came back, and there was no, re-excision. And then he was seeing some sort of a quack who was providing ozone treatment to the lesion. And it was, by the time I saw him, the size of like a dessert plate, right on the crown of the skull. And he just was mostly disappointed that I wasn't prepared to excise it in clinic that same time that he saw me for the consult. Right. And so it was fixed. And so anyway, I just talked it over with oncology and decided, to work it up further with an MRI because I was concerned about invasion of the skull. And I just remember her saying to me, she's from India, and she says, this is not something I'm supposed to see in the United States. I'm supposed to see this in India, because it's just developed country, and you think, well, how is this happening? But you still see these delay in care diagnosis. And then the unfortunate thing about that guy was that it was invading through the skull, through the dura, and actually into the brain. And we had pretty much nothing to offer him besides some palliative radiation. So I sent him to oncology, and they coordinated all that. So that's my, sad classic rural surgery story. I know you've had something similar. So what do you do?
So, your colleague mentioned, you're not supposed to see these things in the United States, but we see them all the time at the VA. I had a patient with a huge basal cell like this that's been growing for at least 15, 20 years. And then a couple scalp SCC stories. I had a patient that came in to me for Mohs. He had a SCC about maybe 3 centimeters in diameter, kind of necrotic appearing. Comes in, I look at it. It's overlying a scar. I'm like, hey, what's this scar from? He's like, oh, I was in an accident. 30 years ago, I had neurosurgery. They put in some hardware. I was like, okay. So I take a look at this squamous cell. I just clean him with gauze, and the whole thing was necrotic. And I'm seeing his plate there. I'm like, oh, this isn't good. So we had to get neurosurgery, or we sent him to UC Davis, where head and neck surgery and neurosurgery had to work together because he needed a free flap because he had no vasculature there. And then that was one case. I had another case. A guy came in with an innocuous looking squamous cell, about a couple centimeters in diameter on his scalp in the middle of it. And I started Mohs. It didn't feel it felt mobile. Wasn't, didn't feel odd. Just his history was he's made bad squamous cells in the past. That was kind of the only red flag. So I started Mohs on this, and my first layer, boom, positive all the way around. My second layer, positive all the way around, positive deep, and almost every section had PNI, perineural invasion, and just kept chasing it. It was down the bone, had to strip the periosteum, and starting from that small tumor, his defect was about 8 to 10 centimeters. It was huge, just down the bone. And clinically, I would never have guessed that it would have been that huge. And I can see how that, if you're just doing excisions, that can become a challenge, chasing those positive margins. Mohs was helpful. I think it was the right thing for him. We ended up doing it over a couple of days because it just took all day. He couldn't handle it. It takes a long time. Once you start processing large amounts of tissue, it takes a long time to process it in the lab. Yeah.
How did you end up closing that?
just granulating it with some Integra. He started granulating, and then we put a split thickness skin graft on it afterwards, and he's going to get radiation for it.
So if you have bone exposed and you granulate it, like how big of a patch of bone can you get to granulate over? I've done that too, and I thought maybe this won't be successful, but then it was.
Yeah, surprisingly, it will heal. I don't love leaving bone exposed because like theoretical risk of like air emboli that gets sucked in there. But if you cover it with, I've been using Integra. You can get granulation from that pretty well. After several weeks.
Okay.
And then, some people will like burr the bone, to pinpoint bleeding, or that might help with granulation. I haven't done that.
Mm-hmm. Now, when you're doing your skin graft, split thickness skin graft, right?
Yeah.
Do you do that in the office?
No, I sent them to the OR to get that done. Mm-hmm. Yeah. I don't have the tool. Sometimes I'll harvest a graft and I'll thin it really thin, but I don't have, kind of dermatome to be able to do that.
Yeah, it's a lot easier with anesthesia too, on the split thickness skin graft. I mean, I think you can do it. We had actually Dr. Heller on, and we talked about split thickness skin graft, one of the earlier episodes, and her technique, which I think's super great, but of course always easier with anesthesia. So, okay, any topics that you really think would be critical for the listener to hear? I guess I had one more question, which is, if I excise somebody and I get a unexpected positive margin, and then you get that referral, like somebody then decides they have discretion at that point and they say, I want to send you to a Mohs surgeon. Is that something that bothers you when that happens? You wish it came to you in the first place, or how do you think about that?
I'm happy to treat that. I think better late than never. I've had patients where positive margins are just left. The surgeons will say, "Oh, and just a basal cell, we'll just leave it," and then years later, it's a huge basal cell. I'd rather get it sent to me so we can take care of it. Get it out of there.
Yeah, and there's nothing wrong with re-excising, but it's that question of where's it at and how much is left. And the thing about it is I'm living it out here, and if I'm sending you somebody with a positive margin, there were 19 other ones that I took out, and I got them healed up, and they didn't have to have that burden of travel. And so I think if you just can find somebody that you have a good relationship with, like if maybe there's a rural California surgeon that's has some contact with you. Do you have a lot of people that contact you directly, or you have a relationship with that are like that, or not so much in the VA?
Not so much at the VA, but we do work with a lot of kind of rural patients. They'll see someone in the community, and then sometimes it's the Wild West. People will do weird stuff sometimes, but they'll refer them back when they can't handle those cases, and we clean them up.
So, I mean, I just want to be an encouragement to both sides of the spectrum for that rural surgeon that's out there to not offer services to patients, to be able to try to keep the bulk of the patients right there for you, which is good for your community, the individual patient, good for your hospital system, and good for you. But at the same time, not be a cowboy either, and then have somebody that you're referring to on a regular basis who then, the more that you have a person or a couple people that you refer to on a regular basis, then, like for me, I've developed relationships where colorectal, I have a colorectal surgeon that I send a lot of things to, but I also do colon surgery myself. And so then there's the borderline ones, and now we're to a point where I can call and I can talk it over. And there's give and take, and skin cancer can be the same thing, maybe with a Mohs surgeon. The problem is they're so busy. It's, you just want to be respectful, but Yeah. So that would be my take on it. Go ahead.
I was going to say, from our standpoint, we collaborate a lot with different specialties as well. Sometimes things will go into the eye, and like I won't feel comfortable repairing it myself because I can't handle the complications. Or tumor will track into the parotid. It's nice to have colleagues you can call up and say, "Hey, this isn't going like I expected. I removed a layer of the parotid. I don't want to go any more." And it's nice to have that. I think in any medical field, have the colleagues that you can, approach and bounce things off of and help each other out.
Yeah. Resources for the busy rural surgeon. You have a derm resource for us.
Yes. So there's a website it's based out of New Zealand, but it's free. And the information they have is pretty good. It's DermNet NZ.org. There are different topics, dermatologic topics with pictures and kind of treatments on it. It works. I think it's a good kind of high level overview.
Yeah, put it in your favorites tab and have it if you have questions and go from there. I'd like to do a bonus how I do it real quick. Benign skin cyst happens all the time. So whatever it came from, call it a sebaceous cyst. So if they come in and they're just there, all right, you just take it out, close it up in 2 layers, generally, correct?
Mm-hmm.
If you see a punctum, include it in your excision, right? What if they come in infected? How do you normally handle it?
I don't like to excise them when they're infected. I usually will give them antibiotics plus or minus culture. And once, schedule them once it's calm.
Yeah. So I always IND them. Do you ever just do antibiotics and no IND?
It depends what I think. If it's huge and it's just like ready to explode, just IND it. They'll relieve pressure. But for smaller things that are inflamed, and I think antibiotics by themselves will work as well.
Okay. And then how long do you wait until you excise? And you always recommend, so I always, like, for example, basically there's exceptions to every rule, but vast majority of the time, somebody comes in with a cyst has been there for 10 years and it just started hurting and got infected. So then I usually just drain it. If there's surrounding cellulitis, I put them on antibiotics, and I usually wait 6 weeks and then re-excise. And it's amazing how, maybe they had a 1.5 centimeter of cyst for 10 years, but when they come back, it's just like a tiny little pock mark and it's just nothing. But I still excise it because I still think that there's an element of a sac there that it'll potentially come back. What do you think about that way that I'm doing it, and how do you do it different?
I think that's a good approach. I would do the same thing. Wait, 6 to 8 weeks, I think, is a good time to wait to let things calm down. And I agree, it'll probably the excision will be smaller if you let it cool down and kind of go back to their baseline.
Yeah, sometimes I have these really, really big ones. They're like 4 centimeter non-infected cyst. And I haven't moved to doing this, but since I've had them shrink down so much on these infected ones, it's like, why don't I just drain that and then excise it later? And it probably will shrink down a lot. I don't make my excision smaller. I have not done that.
Yeah, it's hard to say with those big ones how much they would, if they're already just that big and non-inflamed, because the sac is there. You can dissect out the sac, and sometimes they're pretty big.
It's just such a common thing. I thought maybe I would take the valedictorian's advice. Why not? I got you in front of me. Man, I really appreciate you coming on. This is so awesome. Do you have anything else that you'd like to share with our audience?
No. I think this has been great. Thanks for having me on.
It's been my pleasure.
Good experience, and continue doing this. I think it's pretty helpful.
Yeah, we're trying to create a little bit of camaraderie. That rural surgeon is isolated, even if they're trying to be a hero. You need to have a community. So thank you for listening to this episode of the Rural American Surgeon. If you haven't already, like and subscribe, join the Facebook group, interact with us. We're trying to combat that rural professional isolation, and we'll see you next time on the Rural American Surgeon.